So just to summarize the immunodeficiencies, let's try to come up with a general rule of thumb to help remember what type of infections will result from certain defects. So how about, can you tell me for B cells, what type of infection would you expect? Bacteria, right? In general. Okay, we need those antibodies for complement activation, opsonization, and neutralization. Okay, what about T cells? Viruses, right? We're talking about CD8, CD4. We need that cheering on of those CD4 cells for macrophages to grind up larger pathogens like fungi and Mycobacterium tuberculosis. Flash quiz time. So, real easy. Deficiencies in B and T cells are generally associated with what types of infection? Just to drill it in. Bacteria, B cells for bacteria, and T cells for viruses, / fungi, / TB. So real quick, let's cover grafting from donors to recipients. In general, the more likely the graft is to succeed is if it is HLA compatible, and the most likely to succeed is if this graft is actually from the patient's own tissues. So, let's play a game here. Can you guess where the different types of grafts are from? Da-da-da. What about an autograft? Auto means self, so it's from yourself, okay? Syngeneic graft. Syn means just like, and so it's from your twin, okay? How about an allograft, right? Allo means other, and so it's from the same species but unrelated. Xenograft. In Greek, xeno means foreign, and so this is actually a totally different species, maybe Whiskers the cat. All right, transplant rejections. Last topic of immune responses. And in general, try to think about for each of the four if it's one or multiple types of hypersensitivity. Just to refresh your memory, ACID, right? Our acronym, the types of hypersensitivity. Type 1 was allergic, type 2 was cytotoxic, type 3 was immune complex mediated, and D was delayed type. Now, which ones were antibody mediated? The first three. Which one was cell mediated? The delayed one. So antibodies act the quickest. Keep that in mind, especially for the first one. All right, hyperacute rejection. It's the earliest manifestation of transplant rejection. And what do you think it's caused by? It occurs really quickly. Sometimes the board stim in your exam will say before the surgeon has even finished placing the graft in the recipient, you see a reaction. And so if it's really quick, it must be antibodies, and it is the result of pre-formed, ahead of time, anti-donor antibodies that were formed earlier on by the recipient. And it leads to occlusion of the graft vessels, necrosis, ischemia, and death of the overall graft. All right? Acute rejection occurs weeks after transplantation. So what type of hypersensitivity do you think? Weeks? That seems pretty delayed to me. So probably cell-mediated. All right, type 4. And this is due to, clear up some space here, this is due to cytotoxic T cells rejecting against processed and foreign MHCs, okay? And so here's a cytotoxic CD8 T cell. It treats this MHC as a foreign MHC. Fortunately for this form of rejection, it may be reversed with immunosuppressants like cyclosporin. Chronic rejection occurs months to years after transplantation, and there's a key buzzword. It's obliterative. See that? Obliterans or obliterative on your board stim? Think chronic rejection. And it's due to a combination of both T cell and antibody mediated damage of the host T cells seeing donor MHC complexes as self MHCs, presenting foreign antigens. A little bit confusing there, but that's really a combination of both antibodies and cell-mediated. And unfortunately, this condition is not reversible. Now, graft versus host disease is pretty important to know too. And it's really kind of a fascinating condition in which the grafted T cells proliferate in the immunocompromised host and reject the host cells. The result is a condition characterized by a maculopapular rash, jaundice, because it hits the liver, hepatosplenomegaly, and diarrhea. All right, time for one final test yourself question. A 7-year-old boy is stung by a bee and experiences respiratory distress within minutes. Soon after, he lapses into unconsciousness. What is the reaction mediated by in this child's condition? This should be a no-brainer for you. The answer is obviously IgE. You recall the IgE antibodies synthesized and placed on the surface of mast cells after the first and initial exposure to antigen, such as bee venom or initial sting. But once this poor child is stung again, the bee venom antigens cross-link the IgEs and trigger a release of pro-anaphylactic cytokines that constrict the airway and trigger respiratory distress and potentially unconsciousness or death. Now, what does this child originally need? An emergent shot of epinephrine, 1 to 1,000 dilution, to act on those beta-2 receptors of his smooth muscle in his respiratory tract and reopen his airways and save his life. All right, I'll see you in the next section.